hear me? One of us.
That's me.
Be careful not to move those things around. Welcome. We'll go ahead and get started with our afternoon session on creative disruption of the healthcare system. I'm really pleased to have here today the co-author of the book, The Innovator's Prescription, which I think, as I may have indicated, I think is maybe one of the most important books written on healthcare delivery in this country. That's Jason Wang, Dr. Jason Wang, and also to his right, Ann Christensen, who is president of the Christensen Institute, which was also something you founded with Clay Christensen. The connection of the name is Ann is Clay's daughter, but a very accomplished as an MBA from Harvard and a lot of other fancy degrees that I won't get into right now. But what we want to talk about today is, how creative disruption can save the healthcare system and how it can create opportunities for entrepreneurs. I think, as you heard Steve Burrell talk at lunch, the system basically is going to go bankrupt, and some dramatic changes are needed. I've spent a lot of time in the healthcare space trying to understand what's going on. And when I came across this book, I thought, my goodness, these people really have figured this out. And then after spending some more time with it, really, it's almost 10 years of work went into the book. I know that you weren't on all 10 years, but Clay and his late colleague Jerome Grossman had spent 10 years really trying to really truly understand how does the healthcare system work. And my view is if you don't understand how something works, you can't possibly fix it. And it's extraordinarily complicated, but these guys wrestled it, really got it. And Clay described Jason as a true genius who really wrestled the truth to the ground, and not an easy task. And I know you were very involved in the book, but really since has been working on a white paper, the Affordable Care Act, which we'll be sending out to all of our conference attendees. So that's the broad overview. So why don't we start a little bit, and maybe, Ann, why don't you start? Tell us a little bit of your background and sort of how you got into the business of what you're doing now.
Sure. Gosh, at a very high level, it's kind of a long story, but you're not really here to learn about me. We want to talk about healthcare. So I actually got my initial start in healthcare as a high school student, interning, as many of us did in high school, but at Mass General Hospital, where I actually had kind of my first glances into the healthcare system that's broken, and just saw, even basic processes kind of falling apart. So the patients, Mass General Hospital is a wonderful hospital, one of the best in our country, but where, I just saw little things happening where patients were not getting as good of care as they should. And I became intrigued at age 16 with healthcare, and it was just something that then stuck with me, and something that I then studied in school and went on to consult in and have continued to work in, and then studied as a graduate student, and then now with the Christensen Institute, continuing to try to find ways to innovate in healthcare and make it both better but also more affordable and more accessible for patients. Short version.
Jason, give us your broad brush of what you're doing.
Sure. My background is as an internist, but it was pretty early on in my training when I was in residency at UC Irvine. I very quickly began to realize how to the extent these great heroic measures that my colleagues had to go to deliver good care for their patients. And it's a source of great frustration because you turn around and say, well, the patients are doing well, except that, this is not sustainable. And so, that led me to become a chief resident, which kind of gave me a first taste of what it was like to manage people, what it was like to manage a program and manage facets of healthcare delivery. And soon after that, I said, I should probably go get some real management training, and led me to business school. And that's where I met Ann's father, Clayton Christensen, and was fortunate enough to work with him on this book. And it was during the writing of that book that we created the Christensen Institute to basically continue the type of research that we had poured into the book, because we knew we were certainly going to get some things wrong, new issues were going to pop up, and yet disruptive innovation was just this very useful framework to address all of these ongoing problems that needed to be addressed in healthcare. And these days, I'm now run a healthcare startup company, which hopefully some of you will hear about from my colleague Ian, who's in the audience right now.
Yeah, Polkadot, which is a breakthrough, I guess I would imagine a disruptive technology company, is going to be presenting later on this afternoon upstairs. So you were a Harvard Business School student, and you were taking a class from Clay, and he said, hey, I'm doing a book, and you want to help me finish it, or is that...
It wasn't quite that straightforward. It was more me looking at the various healthcare companies that came recruiting at Harvard, not really seeing myself working for any of them, resolving the fact that I probably had to return back to my hospital and work my way up the ladder. And then Clay just sent out a mass email, not to me, to all his students saying, hey, I'm trying to write a healthcare book. Does anybody want to help me out? And I guess I had the right credentials and the right level of unemployment that I accepted the job.
Well, was it a big success? I mean, I know, as I said, the book, he called you a true genius, and you really wrestled the truth to the ground, and it was a big accomplishment. So, creative disruption, or just disruption, is it some, it's kind of a term that I guess Clay has kind of coined, is it not? And it really looks at how existing industries become changed, to get disrupted, and through sort of a consistent manner. Can you want to take a second and talk a little bit of maybe what is disruption?
So I maybe talk to a little bit of where it came from and let Jason tackle, where it applies in healthcare. Clay initially identified it as a phenomenon probably 20, 25 years ago. And what he had seen was the heads of our country's, the world's great computer companies on the cover of Forbes and Business Week and magazines that we all know touted as geniuses of our day and some of the best managers we've ever seen. And then 5, 10, 15 years later, as some of those companies then also collapsed, the same people on the cover of the same magazines being kind of lambasted as poor managers who drove their companies into the ground. And he said, the kind of quandary he found himself in was smart people don't get stupid. So what's happening here that by continuing to follow best management practices and build great companies, we actually somehow set ourselves up to fail, which became kind of the impetus for his doctoral thesis, where he identified this pattern of companies innovating and by listening to their very best customers, making products that are better and better and better, but in the process of doing so, leaving behind over time really the mass market and your average consumer. And those companies, as they're listening to their best customers demanding really great, kind of very high-end products, other companies kind of coming in at the low end of the market. Toyota in the 1970s coming in with a really lousy car that GM thought would never really threaten them, and actually Toyota innovating and making better and better cars that today are some of the best cars available on the market. And so seeing this happen in industry after industry, he really put a framework around it and created, I think one of the things that makes it powerful is there is now a language and a framework to identify what happens in industries that allow companies to succeed, and then by doing the very things that made them succeed, then also fail. And as he studied that, he really saw a lot of the same patterns starting to happen in healthcare. And as that kind of as a nation, as we have looked at our healthcare system getting more and more expensive and more, frankly, unusable, he really felt the need to articulate what disruptive innovation can do to
so that was really the idea, the original
country.
book that was the Innovator's Dilemma.
The Innovator's Dilemma and the Innovator's Solution.
And the idea is that you could be great and do everything right, but you end up in ruin because someone else comes in underneath and serves those low margin customers, or the customers that no one really wants because you can't make the big margins, but then that's how the little company gets their hooks. Before you know it, they start going up scale, and before you know it, it's too late. And so,
Exactly.
Jason, you want to add to that?
So the difficult leap was then how do you apply that sort of principle to healthcare? When I first started collaborating with Clay, I was a doctor. I'd come out of the system, and so I was one of the many who thought healthcare is just a different industry. You can't manage it like a business. People aren't widgets, et cetera, et cetera. But the first example that I think Clay gave me that really hit home because it was in cardiology, a field that was related to what I had been practicing. And in fact, I think it was the first example we wrote into the book in the early chapter. It was angioplasty, this idea that you could somehow treat patients with cardiovascular disease with a balloon catheter instead of surgery. And so the translation had to be, rather than thinking of high margin and low margin customers, you had to think of high complexity and low complexity medical issues. And so heart disease had always been thought of as something you would manage until somebody was basically in severe distress and needed surgery, therefore high complexity. That demanded surgery. It was the only time you would want to do surgery anyway, because surgery itself was so costly and risky. You wouldn't want to do it on somebody with mild heart disease. And so all of these people with mild cardiac disease were basically left to wait until their cardiac disease progressed to a point where they needed this major surgery. And so there was no solution really offered for this low margin or low complexity patient until angioplasty came about. So angioplasty, if you were to compare it head to head against bypass surgery, was a pretty terrible technology. It couldn't fix the people that were getting surgery. So any surgeon would scoff at this technology and say it's utterly useless. But it did benefit the low margin customers in this case. The people who otherwise were being medically managed, who had no alternative but to wait until the heart disease got bad enough where somebody was willing to operate on them. Not only that, it empowered this whole new set of providers, the cardiologists, non-surgeons, to have this new career path of being an interventional cardiologist. So having that receptive customer, both in the form of the patient as well as the provider in this case, really shone a light for me on what disruption could do and how it could change dramatically how patient care is delivered.
Interesting. One of the things you talk about in the book is that one of the core problems we have in this country is there are no system architects. In other words, there's no larger enterprise that's like looking over the whole thing. And as Steve talked in his lunch today, everyone's sort of figured out a way to carve out their niche. And everyone knows the whole thing's broken, but they're making a living somehow gaming the system to get whatever they need to get, whether it be reimbursement or whatever, to survive. And then because there's no one sort of with an overarching kind of concern, then you sort of are in this problem of, well, how are you ever going to fix this? And I think one of the issues we have in government is because this is a 10 or 20 or 15-year problem, and we have people going into office on 4 and 5 year, 6 year cycles, there's really never anyone there. So that's a conundrum. I mean, on a broad base, what's the outlook? I mean, what can we do? Thoughts?
I can certainly take a stab at it. I mean, in the book, we pointed our finger at several potential orchestrators of healthcare re-architecting. So, most people think of the government as somebody that could do this, but we said really that was a solution of last resort. A solution like that is subject to political whims. It's very difficult to modify and especially withdraw anything once you roll it out. And so it's really to be used as a last resort. And yet it's the model that most countries have adopted. But what if there were other potential orchestrators in our midst in this country that could actually do a better job? And so we also thought that while it's not deployed on a nationwide basis, certainly in many communities, you could say that there's an integrated health system. In this state, Kaiser Permanente is a very good orchestrator of healthcare, it being a hospital, it being an insurer, having their own providers, as well as being a large employer. It has lots of incentives to get everything right, to deliver the best quality care at the lowest price point possible. And yet, if you trace back Kaiser's history, you can find yet another type of orchestrator, and that is this large self-insured employer. Kaiser Permanente started out of a large employer's initiative wanting to get better health care for its employees, and Henry Kaiser eventually opened up his model to family members and the community at large before it became the Kaiser Permanente we know it today. But certainly large self-insured employers have every incentive to want to get their their employees to be healthy and productive, and yet also do it in the highest value way possible. And so much like Henry Kaiser did decades ago, our large self-insured employers today, if they had the will, could potentially create new models of healthcare. And there are, again, pockets of this in various communities around the country, and it's only a question of how do we spread some of that innovation to other communities.
And anything you would add to that?
Yeah, well, I think Jason's exactly right. I think, both the integrated providers and large employers provide the most hope, I think, for disruptive innovation. And one of the challenges for innovation for innovation in healthcare is that it's hard to disrupt yourself. We see, in company after company, where companies have successfully disrupted themselves, what they've done is actually spun out a very separate, very autonomous business unit that is, allowed to operate under different metrics and different margins and different goals. And it's hard to, we keep trying to do things within the existing system. I think ACOs are actually a really, certainly one of the hot topics of the day. Really struggling through this problem right now, where a lot of them, we're trying to squeeze cost out of healthcare and setting up a lot of incentives, but when it's still embedded in the old system, it's hard to really break out of it and do something new and innovative and accomplish all of the goals that you've set up for ACOs. And so, a lot of large employers and a lot of integrated health systems actually, have different enough constraints, I guess would be the right word, that there's more opportunity.
So one
to
example of
disrupt
this
there.
for you guys would be IBM. In the computer business, you guys probably remember control data and digital equipment and a few of these others. Why did they all go extinct? And why did IBM survive? And the reason IBM survived, as I understand, is they created a separate personal computer business away from everything else, set up in Rochester, Minnesota, I believe, that could just go do the personal computer. And the big, I'm sorry? Boca Raton Fire, I'm sorry. And so what that enabled them to do is to do things without having to go check back with corporate offices and this is going to fit and so
It's
on and so
essentially creating their own competitor in-house. And as Ann said, it's exceedingly difficult to do because it goes very much against your short-term interests. You sacrifice some profitability for long-term sustainability. Just as a real-life example in healthcare where this proved to be so difficult, when Clay and I were writing this book in Massachusetts, we were watching these retail clinics, like Minute Clinic, popping up in Minnesota and around the country, and yet the hospitals in Massachusetts fought very hard to keep them out of the state, just thinking that they were going to carve out the simple, high-profit stuff that they wanted to keep for themselves. Eventually, there was a large hospital in Boston that acquiesced and said, "You know what? We'll give it a try." And yet, when you ask them, "What's your real interest in this? Why are you opening a retail clinic?" Is in fact to provide more affordable, accessible care to these people who are looking for something on their block, like CVS is trying to do. But really, if you prodded them, what they were expecting was that these retail clinics would funnel more patients into their hospital beds. As long as it was seen as a source to sustain their sort of parent business model, it would be a success. As soon as it started detracting from that parent business model, it would get shut down. And that's the mentality of not just large hospitals, but of any type of business that's sort of at the top of the food chain.
So Steve actually covered that a little bit in his discussion earlier. Why don't we take a look into some of the major players, hospitals. Obviously, that's a big business in this country. What is your outlook on what has to happen and how hospitals will function in the future? People say that there's 30% more occupancy than is needed. Is that your sort of assessment? And what do we do with these hospitals? Any thoughts?
Go ahead.
So, there's people who have read our material often come away thinking that our job is, or our mission has been to shut down hospitals and put doctors out of business. And it couldn't be further from the case. It's really that we want hospitals available for the people who really need it and for when we really need it. And under the current model, the fact that they are only around because of large subsidies, because of philanthropic, and charitable donations, it's not a sustainable model. And so how do we make it sustainable? I think disruptive models of acute care that we've looked at are great ones to follow. So for example, Presbyterian Healthcare Services in New Mexico, they've been the largest adopter of something called the Hospital at Home program. And so they have the same dilemma that many hospitals around the country face, which is, our hospital beds are full. We know we're going to keep getting patients, so do we build yet another new hospital? Or do we figure out a way to deliver this same care, but in a different setting that's more affordable and accessible? And so they took this program, pioneered out of Johns Hopkins, this hospital home program, which is to figure out, well, are there some patients with pneumonia and COPD exacerbations and congestive heart failure exacerbations who previously all would have been admitted, but maybe now with better technology, we can monitor their home, we can send our healthcare professionals to visit, we can send all the treatments to their home and see what happens. And not surprisingly, costs were lower, but outcomes were better. Length of stay was shorter, and above all, patients were happier. And so, they released an article in Health Affairs which showed all of these statistics, but they didn't even bother including the savings from not having to build a hospital. Another international example comes out of Denmark, I believe, where they've actually been shuttering their hospitals at a very rapid pace, basically realizing that with telehealth they can deliver a lot more care outside of the traditional confines of the hospital and clinics that we've all grown accustomed to. And so Kaiser Permanente here has gone as far as issuing a challenge for architects to design the small hospital of the future.
And you see hospitals, people trying to shut hospitals down, and what kind of political pressure or environment will create an opportunity to begin to change the hospital structure?
Sure. Well, I think there's a really interesting and exciting question for innovators here on kind of what business models we can set up. Jason wrote a great article, a great blog post in HBR last month on why we haven't seen greater uptake in retail clinics. And part of the takeaway is just in regulatory obstacles that there are. We've also seen a lot of small surgical centers that are really focused on specific kinds of surgeries and actually have better outcomes and are cheaper and get patients in and out faster. And part of the problem that Jason and Clay really articulate well in the book is that hospitals as they exist today are conflated business models trying to be everything to everyone. And I think the hospital of the future, it needs to be a simplified business model, that there are, patients that do need all of the complicated equipment in the hospital, but the more that we can actually drive, patients with lower acuity problems to other settings through a lot of the technology that's emerging today, and allowing kind of practitioners to practice really to the top of their training and allow nurse practitioners to be tracking patients, who are at home, is actually going to change the hospital as we know it, but in good ways that actually allow patients better access to care.
So one thing on the hospitals that I think is interesting in the book is you talk about conflated business models. It's, people are saying we're all things to all people. And there's a lot of community pride in the hospital. And they need to fill the beds. They got the beds, you got to fill them. So now you say, hey, we can do surgeries, we can do this, we can do that. It's like a manufacturing company say, listen, we make great chairs, tables, cars, speakers. It's preposterous. But that's essentially what the hospital is claiming.
Yeah, and I think a relatable example that I believe we also used in the book was, your dealership as a mechanic. Your dealership obviously is qualified to provide all the services your car would need. The question is, should it be your one-stop shop for everything? Or for routine maintenance, is there a space, is there a role for a company like Jiffy Lube where, something routine, something that's low cost could be made even more convenient by just creating all these shops that are available without appointment all around in your neighborhood. So it's sort of that mentality. Or can we carve out things out of this hospital model so that it's no longer such a hospital-centric model, it's not a one-size-fits-all model, but basically everybody gets to do what they do best.
Interesting. Probably moving on a little bit to the Affordable Care Act, and make sure we don't run out of time. You guys have done a nice paper on the Affordable Care Act, and you've analyzed it from a disruptive perspective, what's good about it, what's bad about it. And can you take a minute here and talk about what your white paper was and what you saw some of the big pluses and negatives with the Affordable Care Act?
Sure. And so essentially what we did, we published a paper, I guess in this last October of 2013. And the general thrust of the paper was, love it or hate it, Obamacare is here. And we've got to live with it. And so if I'm an innovator, or if I'm a policymaker, or somehow, a stakeholder in healthcare, how do I think about it? And we went through kind of provision by provision and said, is this particular provision something that's likely to encourage innovation in healthcare, or is it likely to discourage innovation in healthcare? And we said, for those provisions where it's encouraging innovation, entrepreneurs have at it. There's really a lot of great opportunity here. And for the provisions that are discouraging innovation, those of you who hate Obamacare and those of you who are involved in policy, let's focus our reform efforts on these things. So, on the more positive side, we think that there's a lot in the individual mandate and the employer mandate, for example, that are, requiring obviously employers to provide coverage and individuals to carry coverage. And what's complicated about that is that we're pushing a lot of people into what is, already a very congested system. And so it actually, we think, creates a lot of demand for, we think, things like retail clinics, a lot of telehealth, remote monitoring, a lot of the businesses that we see emerging in healthcare today. We think it creates a lot of new demand for that, and that there's a lot of opportunity for new entrants in that market. Similarly, we think ACOs drive a lot of opportunity for innovation, where really what ACOs are set up to do is incentivize providers to reduce the cost of care. And so, a lot of technology that enables better patient monitoring, practice management, things like that. Actually, there is a very hungry market out there for technologies and systems that can provide better outcomes and more affordable care for patients.
Well, on the flip side, then, there's some problems.
On the flip side, there's absolutely some problems. I would say, very broadly speaking, from a disruptive innovation standpoint, there's a few provisions that really kind of kill the low end of the market.
Which kills the notion of innovation.
Yeah, you can't have disruptive innovation without a low end to come in at, if that makes any sense.
And so that's the notion of this minimum level of stuff you've got to buy. Everyone's going to buy this sort of silver level of healthcare.
Yeah, and so when you get rid of the bronze packages, the bronze plans, and you have minimum essential coverage, there's kind of a floor then in the insurance market where it's hard for innovators to come in with new kinds of coverage,
So does it basically stop the healthcare costs from going down? In a sense, haven't the government said, listen, we're just going to, everyone, we're going to spend this much and we don't want to spend less? Is it almost a perverse result that we're getting from that?
It can have perverse ramifications when it comes to disruptive innovation, because as Ann said, you really need that market, that lower end of the market of non-consumers, people who can't really afford or can't access the gold standard.
So are you saying that Obamacare has basically eliminated the ability for us to provide to people that can't afford
It's
things?
eliminated some of that low end. There is still stratification, so it's still possible to come up with, for what is an Obamacare now, the new low end. But again, it would have been interesting to see what insurers could have come up with had there not been, formally established four-tier model of insurance.
So that's almost just absolutely, it's like almost a centrally planned economy concept, right? And the Soviets tried that and it didn't really work so great. Are we basically doing that here in the United States with healthcare?
I think it remains to be seen. There's certainly still lots of room for innovation in healthcare, right? You see a lot emerging in the technology space. You see a lot emerging in the provision of care. But one of the things that Clay and Jason articulate in the book is that for disruption to happen, you need an enabling technology, a business model, and a coherent business model. they're in a coherent value network. And, you know, in the same way that you know, a lot of people will say the internet was disruptive. The internet actually itself was not disruptive. It was an enabling technology that allowed a lot of things to be disruptive, right? It is an enabling technology that allowed Amazon to be successful and kind of start putting Barnes & Noble slowly out of business, for example. We've all watched that one. And similarly, we have lots of technologies coming, you know, emerging in the healthcare space and things that are helping drive down the cost of care and improve patient outcomes. But when you look in the larger context of business models and a coherent value network, when we're limiting the ability of payers and providers to ratchet down the cost of care and innovators to come in with really new business models, then we're starting to restrict our ability to disrupt. There's still, I think, some interesting possibilities within integrated systems and spaces like that. But overall, when you restrict the system,
So
it's hard to have complete disruption.
We talked recently in terms of new models, and that some of these things can happen on a regionalized basis, but it's very difficult to do that on a global basis, or in other words, the entire United States.
Yeah.
The whole notion of states testing ideas and seeing what works. Obamacare doesn't really give us that opportunity now. We're all into this one. Does that your paper find that? Is that what you guys see now with the Affordable Care Act? We've got one size fits all, and
I mean, not entirely, right? There's certainly, you know, as Jason says, a bit of stratification within the kinds of plans available and the types of coverage. I think also, you know, there's a lot of there's interesting things happening within integrated providers. There's also interesting things that, as Jason said at the beginning, you know, employers can do to try to provide a coverage for their employees. And so I think, you know, it remains to be seen where the innovators will step up and where the business models will emerge. But there's certainly opportunities to create.
One of the things you talked about before was the notion it's hard to disrupt yourself, and you guys did this tremendous book, and you went out to the world to share the book with people, and you didn't get quite the response, right? The uptick or the demand that you would like. And I think someone was talking, maybe was that people didn't really want to hear it. Those are just a dump of business guys. They don't get it. They don't understand healthcare. Was it that, or they just didn't want the news? I mean, we're telling them that they got to completely change everything they do. What's your sense?
So part of it certainly is that even people who accepted the message, who understood that, you know, what we were describing was this phenomenon that was observed in every industry time after time, healthcare needed to prepare for it. It was still not easy to dramatically change what had been successful for so many years. You know, pharma being the most profitable industry in humankind, what reason could you see as a pharmaceutical leader to want to change your business model? Hospitals, you know, if you looked at their metrics of success, able to save people who previously, you know, just years ago would have died. I mean, able to do extraordinarily capable things. How can you view that as a failure? Why would you want to change it? The best doctors in the world coming out of our medical institutions, why would you want to change that? So when you look around the system, you know, if you're just playing that one role in the entire system, you don't see much impetus to change, I think. It's those of us who are looking at it from a more systemic view see this innovator's dilemma, which is we built this gold standard which is simply unsustainable, and that the only way to make it sustainable was to look for alternative models of delivering care in new ways that were indeed sustainable. But the people who were already in business, who are existing stakeholders, it's really tough for them to lead the change. And again, disruptive innovation tells us that it is why all of this change very often comes from outsiders.
Right. And that change has to happen, right? Because the projections now are that we're going to consume all of our country's resources paying for healthcare, and within 10 years or 20 years, you guys know the statistics, but it's, so what's going to happen? I mean, what has anyone thought about, like, well, what actually happens? Do people that used to get $300 a week to pay for some drugs and such, now they say, I'm sorry, we can only give you 200 or 100, and then someone who's barely surviving now basically can't? I mean, what happens to society? And you can't just keep printing more money, right? I mean, does the whole thing come unraveled? I mean, how serious is this problem?
You want to predict the apocalypse?
The question is, do you want to predict the apocalypse? Depending on how you spin the numbers, the future looks bleak. And I think if we continue on the current trajectory, and I don't think that's really lost on anyone.
But we are, right? Obamacare
correct.
doesn't change the trajectory.
But I think what we have to wrap our heads around is the government's not going to fix it for us, but nor is this problem going to go away. And so as innovators in the healthcare space, the burden is actually on us to figure out the technologies and the business models to change healthcare, because it's not going to fix itself.
But if you have something,
as Jason has just referenced, the kind of the incumbents in an industry are also never the people to disrupt themselves, and so it really the change may have to come from outside. It may be. But
if a third of all payments are from Medicare and Medicaid, right, a reimbursement, and you can't get reimbursed unless there's a code, that means by definition you can't have an innovation because codes don't exist for things that haven't been invented yet. So how do you deal with that?
So it's awfully tough. This pricing schedule that exists is unlike really any other industry. It forces a startup to have to slot itself into some sort of existing code in order to figure out a way to stay profitable and to find its place in the system. My own company has decided to bypass any attempt at working with insurance and just charge cash only. And the only way we were able to do that was to make it so affordable that patients didn't need to involve insurance. Outside of just bypassing the system, bypassing incumbents, I think it's really the only way to change from the outside. Otherwise you risk being co-opted by the rest of the system and just playing the game.
So basically, the future really is just just pay, private pay, right? I mean, if your innovations are not going to come from reimbursement situations because of the stuff.
Yeah, I mean, insurance still has a role, but insurance needs to be insurance, which is to cover those unpredictable high-cost events. The way we've been using it as sort of a reimbursement machine for every single little procedure and technology has to go away.
Right, I mean, like you don't have grocery insurance, do you?
Right.
Or clothing insurance, but yet we have that for healthcare. So getting back to sort of like what's going to happen, I mean, what is the scenario?
You have the rest of the world kind of waiting to see what's going to happen in the U.S. because we're so far and away ahead of everybody else when it comes to percent of GDP spending. They're waiting to see what we're actually going to have to cut. Are we going to let our bridges start collapsing, our roads start deteriorating, or are we going to have to cut military spending? Are we going to have to cut other education support? We don't know. This is uncharted territory. The only examples that I can think of in recent memory are all these austerity measures that got placed in Greece and Ireland and Italy. So this is really uncharted territory for a country like ours.
And you want anything to add to that? I mean, is it that grim? I mean, we're talking about bridges collapsing because we have to pay for healthcare.
I mean, it's possible, right? I think it's up to us, and I think there's opportunity for it. I think, what Jason has talked about his, company where they've actually made this decision not to pursue reimbursement but to be cash only. A lot of innovations. We were talking about retail clinics earlier. Minute clinics started in Minnesota because nurse practitioners could, or part of the reason it was successful was nurse practitioners could write prescriptions. And they were able to then go to other states where actually nurse practitioners
So this is in Minnesota?
Could originally, where nurse practitioners could not write prescriptions and say, actually, there's a place where this works, and use, kind of operating at the very, not outside of regulation, but at the very edge of regulation, demonstrate something that works, that, does not compromise patient outcomes, but actually both saves costs and provides better, more affordable, more accessible care. And then there's a business model that actually insurance companies start to actually want to drive patients to something that's more affordable. And as you start to prove business models, I think you'll see, uptick and uptake of goods and services that actually improve care. But we've got to create those businesses kind of on the margins and bring them into the mainstream.
And I think it gets to your point that fortunately, because it's, despite what detractors of Obamacare will say, it's not a state-run system. There are still lots of pockets of opportunity, state to state, community to community. There are reasons that personally my company opened in California and it's not in, say, Texas. There is still enough differentiation across the spectrum here that you will find pockets of innovation where you can demonstrate projects and disruptions that work, and then hopefully allow it to spread from there.
We should make sure we have some time for anyone who wants to ask questions. Go ahead.
This whole debate in Obamacare, you got 31 million people. No one has ever explained where I can read or see who's going to treat the 31 million new people. There are only 10,000 doctors that are being graduated every year. And what's that going to do to waiting times?
It's a great question. I mean, basically, we were already in a position before the Affordable Care Act having to figure out how we were going to supply care when we were facing nursing and doctor shortages, as well as an aging population. So this was already a problem. Now we've accelerated this issue. So basically, I think these are the sorts of opportunities that Anne was relating to when she said, with this increased demand comes an opportunity for innovators to come up with alternative models to deliver this care. My short answer to you is, who's going to deliver this care? Probably not doctors. Or software. Or patients themselves armed with software, armed with smartphones.
Right. The whole notion of networks where people begin to share.
Patients helping other patients, peer educators, lots of different models out there. Not necessarily the doctor's visit. That doesn't have to be the gold standard anymore.
Oh, thanks for a really good presentation. Just wanted to say that the two most negative things that you had to say, that Obamacare didn't do enough to prevent healthcare costs from rising, what are we going to do? And also that because of its requirements of what has to be done, that is an inhibitor in innovation. I think in reality, you take those two things together and make it really positive innovation. Because as costs keep going up, what's going to happen is providers are going to get less money. They will need to figure out a way to do things more efficiently. The hospital won't have the choice of staying open and doing minute clinics to feed it. It's going to have to find a way to shut some things down. So there's a required market for innovation that's devoted to providing a certain level of service, maybe a little lower than we have now, but at lower cost. So I think the whole thing is very positive in the long run, although a lot of short-term disruptions. But the question I want to ask is, Jason, what are you actually doing to take advantage of the current environment? You just mentioned a couple of things in passing. I just wanted to hear more of a full description of how you thought you could take advantage of the environment.
I've been able to benefit from 5 or 6 years of being able to see what were the best disruptions out there, what were the hallmarks of good innovation that could really make a difference in healthcare. I have basically a whole assortment of ideas that I think should be implemented, and if not me, I would love to have somebody else do it. The company that I'm working on, again, my partner Ian will have the honors of presenting that. But basically, in my mind, the most important trends that we need to take advantage of are basically moving care out of this so-called gold standard. We need to realize the gold standard of hospital-based care, doctor-delivered care, has actually not been a true universal gold standard. If you live in a remote part of the country, if you happen to be uninsured, if you were poor, if you were busy working that day and could not take time off work to go see the doctor, healthcare was not really that accessible even through the gold standard. So I think the prime objective is to find a better way of delivering just as good care, if not better, but in a much more accessible and affordable way. So how can we use, for example, smartphones? Nearly ubiquitous, already subsidized by another industry. Why can't we use that platform for future healthcare delivery? Using software to automate a lot more of this decision making that we used to make solely in the doctor's brain. And those doctors' brains were just too expensive, and no matter how much money we poured in, we could not convince enough doctors to move out to the countryside. There has to be a new way of delivering that level of care. And empowering patients through health savings accounts to have the monetary incentive to make their own decisions, but also giving them the right information and tools to make better healthcare decisions about themselves. So these are, I think, some of the most important trends, and they tend to filter into the opportunities that I find most attractive and innovative.
Time for one more question?
You're talking about
Go ahead.
You're talking about moving off of the gold standard of hospital-based care. I think another problem that we have is that we have a gold standard or a platinum standard of regulatory burden. And what do you think about delivering better and cheaper care by reducing the regulatory burden?
Yeah, absolutely. I mean, look, there's a reason that healthcare is regulated so heavily. I mean, it goes back to the days of early FDA wanting to prevent snake oil salesmen from preying on people who are sick and in need. But at the same time, you never want government to really get in the way of innovation. And so I think it's a delicate balancing act. I've spoken to many of these regulators, and these are people who want innovations to get out there, but at the same time have this directive to protect the public interest. So it's not an easy answer, but I would say that in many places we need a re-examination, because what I'm seeing is this double tier or double standard applied to, for example, devices and technologies that we give to professionals and the ones that we're willing to hand over to consumers. So as a quick example, early pregnancy tests have been available for years and years. Very cheap, very easy for women to buy it off the shelf, quickly confirm whether or not they might be pregnant. And yet, despite the sophistication of these tests, despite it's been made so simple to interpret, no doctor accepts that as a piece of medical data. They will have to repeat that test in a professional, expensive lab before they are willing to act on it. Can we devise a model where that data can actually be used? I think we need to figure out that divide in order for smartphone-based care, for home diagnostics, to ever be accepted as part of the medical establishment.
Well, thank you. I'm sorry we're running out of time. I would strongly encourage all of you to get this book and read it. It will really give you a true understanding of how the healthcare system works, and I think you'll find it very helpful in growing your business. Let's thank our panelists today for joining us. Thank you, guys.